Hello and welcome back to my YouTube channel. In this video, you will learn about examination of reflexes that may be superficial and deep tendon reflexes. Now have a look at these contents. First one is purpose of examination, then upper limb tendon reflexes, lower limb tendon reflex, other reflexes, abnormalities of deep tendon reflex, grading of reflex, superficial reflexes and neonatal reflexes, and in the last slide you will see about the references from where all these reflexes are given. Now, what is reflex? Reflex arc requires a stimulus, a sensory pathway, a link with a motor unit, a motor neuron, and a effector element. As we have already studied about the reflex arc, this requires a sensory stimulus and a motor response, and in between both these, we require an interneuron or central brain center which utilize or associates these two stimulus and response together and make a coordinated reflex. So whenever a stimulus comes, the body respond through motor neuron and give a reflex mechanism. You can see about reflex arc in this diagram, and I am putting here a link in the description box for reflex arc mechanism. The purpose of examination is to check whether the reflex is present or absent. If it is present, or you have to check that whether it is normal or showing some signs that influences from higher centers are defective. If absent, whether the arc is breached on the motor or sensory side. Breached mean either the arc is broken or not, the signals are completely present or absent. Whether any abnormalities are unilateral, bilateral, affecting all reflexes, or whether a definite level can be detected in the nervous system at which abnormalities first appear, because reflex travels may be helpful as sensory level. Let's see the reflexes of upper limb. First one is the biceps jerk, C5. Now see the patient position. Relax the forearm on examiner's hand. Place the forefinger gently on the biceps tendon and then strikes the finger with the hammer. Normal response is flexion of the elbow and visible contractions of biceps seen. The second reflex of upper limb is the supinator jerk, and its value is C5 and C6. You have to relax the forearm on patient's body at pronation state. Strike the lower end of radius about 5 cm above the wrist. Watch the movement of forearm and finger. Contraction of brachioradialis and flexion of elbow will be seen. Also, slight flexion of finger may occur. And whenever you see the contraction of brachioradialis and flexion of elbow, then you will see the presence of supinator jerk. The third reflex is triceps jerk. Its root value is C6, C7. By holding the patient's hand, draw the arm across the trunk and allow it to the loosely in the new position. Then strike the triceps tendon 5 cm above the elbow. Extension of elbow will exhibit triceps jerk and visible contractions of triceps will be seen. Now after upper limb there comes the lower limb reflexes. The first one is knee jerk and its root value is L3 to L4. Patient will be in supine position. Flex the knee 60 degree by placing the forearm under the knee to be tested. Strike the patellar tendon midway between its origin and insertion. Extension of knee and visible contraction of quadriceps will be seen, and it will indicate the presence of knee jerk. It can also be done with patient in high sitting on bed and leg hanging at the edge. You can perform knee jerk in two positions, supine lying and in high sitting. Second lower limb reflex is ankle jerk. Patient will be in supine position, hip externally rotated, slightly flex the knee, dorsiflex the ankle by examiner as to stretch the Achilles tendon. You will slightly flex the knee, the medial malleolus will be facing upward, then strike the tendon on posterior surface. The calf will contract and moves the ankle. The plantar flexion of foot can be felt by the hand of examiner. Its alternative method is to ask the patient to kneel on the chair so that the ankle are hanging loose over the edge, then strikes the Achilles tendon. The normal response is plantar flexion of the foot and contraction of gastrocnemius muscles. Now see the abnormalities of deep tendon reflex. First one is pendular movements. Pendular movements are the slow oscillatory movements instead of brisk movements. Brisk movements are those that are very rushy and fast, and slow oscillatory movements are that move the joints to and fro. And pendular movement is one of those oscillatory movements that are developed while eliciting a tendon jerk. It occurs because of hypotonicity of muscles. When muscles lose their tone and become hypotonic, then pendular movements most commonly occurs. These pendular movements most commonly occur when you elicit the knee jerk or patellar tendon reflex in patients affected by cerebellar lesion. In normal conditions, after the extension, the leg returns back to resting position immediately and showing us the presence of to and fro movement. In cerebellar lesion, the leg swings forwards and backwards several times before coming to rest. Because in cerebellar lesion, you may face some kind of vertigo and balance in coordination. Normally, number of oscillations is 3. The second abnormality is hung up reflex. The movement is retarded, especially during delayed relaxation, so that the impression of a slightly slow motion film is obtained. The reflex is appearing to hang up, means the reflex will be slowed down and stop there, and you will get an appearance of hanging up. As compared to a normal jerk, it is mainly seen in hypothyroidism. Let's see the grading of reflexes. It grades from 0 to 4, 0, 1 positive, 2 positive, 3 positive, and 4 positive. 0 means reflexes are absent and it will indicate lower motor neuron lesion. 1 plus indicate reflex is present but depressed and it means normal reflex but may indicate neuropathy. 2 plus will indicate presence of reflex and it may be brisk and it will indicate normal response. 3 positive and 3 plus will indicate very brisk or increased reflex and it means there may be normal but may indicate upper motor neuron lesion, and 4 positive may increase clonus and this will indicate upper motor neuron lesion, and clonus means high amount of fast and brisk reflexes. Hoffman reflex. The terminal phalanx of patient middle finger flicked downward between the examiner's finger and thumb. Instead of hyperflexia, the tip of other finger will flex and the thumb flex and adduct. It is a sign of unilateral pyramidal tract disease. The other reflex is Rosolimus reflex. The patient will lie supine with the leg extend and the foot partially dorsiflex. The ball of the foot is then stuck with the hammer and it is hypertonic state. There is a brisk contraction of all toes and normally there will be no response. When the patient supinate his hand slightly flexing the fingers, the examiner will pronate his hand and links his similarly flexed fingers with the patient's. Both then flex their fingers further against each other's resistance. Normally the thumb will extend through the terminal phalanx and may flex slightly, and this will indicate Wattenburn sign. In pyramidal tract lesion, the thumb will adduct and flexed strongly, as you can see in this picture. The other abnormalities of tendon reflexes is exaggeration. Reflex may be excessively brisk, the movement being a sudden, short-lived jerk. This type of reflex is seen of upper motor neuron lesion. Also, it is seen in fright and flight conditions, anxiety after violent exercise, but then return to normal on rest. The reflexogenic zone may be increased. For example, if the bicep reflex is exaggerated, it may even be obtained by tapping over the clavicle due to increase in reflexogenic zone. A reflex may be clonic It means the muscle that has been stretched goes into clonic contractions until the stretch is relieved. It is seen in pyramidal disease and in tensed individuals. Then the other abnormality comes, it is reduction or absence of any reflex. It will occur when there is any kind of defect, when there is breach of any part of the reflexes system. For example, sensory nerve, polyneuropathy, sensory root, tapes dorsalis, anterior horn cells, poliomyelitis, the anterior root, spinal compressions. During cerebral or spinal shock phase, which can be of some hour to some days, when great rigidity, spasticity, or muscle contractions occur, then there may be reduction or absence of those reflexes. Now, see the superficial reflexes. Abdominal reflex. In this reflex, the patient should first lie flat, palpate gently to assess the degree of relaxation and sensitivity of the skin. As you can see in this diagram, explain the patient firstly the procedure. Lightly stroke the abdomen with a pencil, key or with any kind of hammer in all quadrants of abdomen and lower margin of the thoracic case. Normal result, the muscle contract and umbilicus moves in that direction. Segmental innervation, epigastric is T7 to T9, upper abdominal innervation is T9 to T11, lower abdomen is T11 to T12. The abnormal response is exaggerated abnormal reflexes will occur in psychoneurosis and nervousness. Absence of reflex will be seen in upper motor neuron lesion. The other superficial reflexes are cremasteric reflex and anal reflex. The cremasteric reflex is elicited when the patient lies supine with the lower limbs in a slightly abducted and externally rotated position, with the handle of the knee hammer lightly stroke the upper and inner aspects of the thigh. The normal response will be immediate contraction of cremaster muscles that will pulse the ipsilateral testes. Now see the anal reflex. Slightly scratch the perianal skin, which will contract the external sphincter muscles. Position the patient so that the knee is slightly flexed and thigh will be externally rotated. The foot is rest on the couch. Ask the patient to let the foot remain closed. The outer aspect of the sole is then firmly stroked with the blunt point end of the knee hammer. Then curve the stimulus towards the middle metatarsophalangeal joint. Do the stimulation slowly and allow yourself to see what is happening. Normally grade toe flex at the metatarsophalangeal joint. At the same time, other toe will flex and close together. And this is all about the plantar reflex. Extension of the great toe at the interphalangeal joint and the other toes open in a fan-wise manner or fanning of the other toes will indicate Babinski sign, and it is present in upper motor neuron lesion above L5 segment, as you can see in this picture. Now in this slide we will learn about neonatal reflexes. First one is the grasp reflex. Touch the palm with the fingers of examiner on the radial border between thumb and index finger. If the grasp reflex is present, the fingers will be held tightly by the hand in the first instance. The reflex is normal in the babies. Also it is present in mental deficient persons, birth injury, vascular accidents, or in premotor cortex lesion in corpus callosum. This can occur in normal aging. Gabbler tap. Tap the gabbler root of the nose repeatedly with one finger brought from above and behind the patient's head. Normally there is blinking response only to first 2 to 3 taps. In Parkinsonism, the blinking continues as long as the tap given. Now comes the sucking reflex. Touching the corner of the mouth produces a sucking movement of the lips and deviation of the mouth in the direction of the stimulus. This is normally present in infants. This is also seen in advanced and diffuse cerebral atrophic lesion and traumatic lesion. These are the references from where this lecture is given, and I hope you like this video. Do not forget to like, share and subscribe.